Hello, is that you, Judith? Judith, I don't
Hello.
think we can hear you yet, but
Okay, yes. Here we go.
there you
Hello.
go. Great. It's great to have you on board. And ladies and gentlemen, a warm welcome from a very cold and windy and rainy Cape Town. It's wonderful to have such weather here. And it gives me great pleasure, ladies and gentlemen, to welcome Dr. Judith Kluger, she, her, to our webinar this afternoon. And she's going to be speaking about urological conditions in pregnancy. Now, Judith, she, her, it's wonderful. We've had you before many a time. You've spoken on family planning and contraception. So we understand that you're now a fellow in urogynecology at Tygerberg and the University of the Western Cape. So it's really nice to have you over here with us. We also have Steve Jeffrey, Professor Jeffrey. He hasn't joined yet, but he is going to be joining very shortly. Oh, there he is.
Yeah,
oh, there he is, Steve.
Yeah.
Steve, it's wonderful to have you as well. I see you growing a moustache now. Steve, is that true, or is it just...
I think it's just the way the sun is hitting me. So
it's just the way the sun's hitting you. Okay. Well, thanks very much. Now, what's happened is my wife has just given me a cup of coffee. Well, a coffee mug with some wine in it, so people think I'm drinking coffee. Lovely. So it's lovely to have you over here. The sponsor this week is the Pelvic Floor Foundation of South Africa. Just a quick congratulations to Karain. Some of you will be aware that Karain has just had a baby. So on behalf of the Pelvic Floor Foundation of South Africa, I'd like to congratulate her on motherhood. Steve, I have introduced Judy Kluger. You know her, and it's lovely to have her back. So without further waste of time, I'd like to say urological conditions in pregnancy. Over to you, Judy.
Okay, thanks for the invitation. So to tell you how I came about it, is that the beginning of this year, I messaged Karen to say, what's the program? And she said, would you like to talk? And then I said, okay. And then she said I could choose anything. And because I'm a obstetrician and gynecologist, been a general specialist in the state sector for a while, and busy having my midlife crisis, that is doing a urogynecology fellowship, I thought, let me talk about something that is common to an obstetrician, but not necessarily with a urogynecology focus. So I am by no means an expert, and this is not something that I've usually spoken about, and I am going to rely on the more experienced audience to fill me in where I have left things out. But I thought this would be a good way to bridge the crossing from an obstetrician to a urogynecologist. And but most of the things I talk about is actually something that that you see every day in a general practice. So I read this one article that said pregnancy and delivery are the biggest and most perilous stresses on the female pelvic diaphragm. So in the past, I always said family planning saves lives. Now my mantra is family planning saves your pelvic floor. So that's how I've changed. Just to give you a summary of what I will...
Judy, are you going to share your slides? Or,
oh, yes. Thanks. So did I not do that?
Well, I can't see them.
We haven't had any slides shared. Yeah. And while she's sharing the slides, just if I could congratulate you on your fellowship of the Royal College of Obstetricians and Gynecologists. Well done.
Yeah, thank you. Okay, sure. Sorry, good thing you stopped me there.
It's okay, because we're only looking at Pete's shirt all night. So
okay, so just to give you an outline of what we'll talk about today, we'll talk about the physiological and anatomical changes that occur in pregnancy. We'll talk about common urinary symptoms and urinary incontinence that occurs in pregnancy and postpartum. urinary tract infections, urolithiasis or kidney and ureteric stones, and then urinary retention, and then traumatic injuries to the urinary tract with childbirth. So as a general specialist working in Paarl Hospital for the last 4 years, I've had to come do a lot of things that the urologist would normally have done because there wasn't a urologist. So things like fixing bladders at the time of Caesar, which before I was always spoiled that there was somebody around who helped with that, or just checked that I was doing the right thing. So to remind you about the physiology, the changes that occur in pregnancy. So there are many things that happen. And basically, pregnancy is a state where there's decreased systemic vascular resistance. Also, the vascular resistance in your kidneys decrease. There's also increase in plasma volume and increase in cardiac output. And as a result, there's a 50 to 85% increase in your renal plasma flow, which causes an increased glomerular filtration rate and subsequently decreases your creatinine, urea, and urate. But also things to think about is that the actual tubular function of the kidney changes. There's an increase in glycosuria and an increase in calcium excretion. And these things you need to bear in mind, especially when you're thinking about the risks of urinary tract infection. There's also anatomical changes, which I will talk about a little bit later. But this is just to give you an idea on how these physiological changes cause an increased creatinine clearance and how your reference ranges on your serum biochemistry will change. And I always used to chuckle when the medical students would come and say, "Oh, Dr. Kluger, the urea and creatinine is low. What must we do about it?" And then I would like roll my eyes and say, "She's pregnant." So talking about the anatomical changes that occur in pregnancy, the kidneys actually increase in size. And this is due to both the vascular volume and the interstitial volume increases about 1 to 1.5 centimeters. There's also dilatation of the renal pelvis, and this starts as early as 7 weeks. And this is due to the progesterone's muscle relaxant effect. So progesterone is smooth muscle relaxant. And then later there's the mechanical effects of the dextrorotated pregnant uterus. So that's why by the 3rd trimester, there's 90% of pregnant women will have a physiological hydronephrosis, where right is more than left. And I always remembered that the right AP diameter of the renal collection can be anything up to 18 millimeters and your left up to 5 millimeters. And those, anything more than that would be something to really worry about. There's also the loss of tone and contractility of the renal pelvis and the ureters, and that is also due to the progesterone muscle relaxant effect. But there's also...
Judith, can I just ask, if you don't mind us interrupting, do those changes always go back to normal? And is there any consequence in terms of infections from the hydronephrosis and hydroureter?
So yes, I will talk about urinary tract infections and hydronephrosis. And I think this is often also the dilemma is this just physiological hydronephrosis? Is this something that implies underlying pathology? But even this physiological hydronephrosis can return to normal. But yes, it does increase your risk of urinary tract infections. And I'll talk about that a little bit later. The bladder also changes. There's this because of the compression of the uterus, it is displaced upwards and anteriorly. And basically it becomes an abdominal organ. So whereas before it's a pelvic organ, by the 3rd trimester, it is an abdominal organ. Also, the urethra is elevated and stretched, and there's reduced bladder tone and bladder sensation. So now I would come to my first poll. So Wendy,
Sorry,
I don't
Jenny,
know if you
can I just bring up something that I've always wondered about? I don't know if you picked up any of this in your reading, and maybe Pete can also give input. I'm seeing more and more patients as well who've had a pregnancy but seizures, but still presenting with incontinence, prolapse. Did you pick up anything in your reading around this as to the actual risk of a pregnancy on the pelvic floor rather than a delivery, which has always interested me, but I've never actually really been able to delineate it very well.
So
I don't
from
know.
what I didn't go into in depth in that, but
Yeah.
from what I've read is that doing a Caesar is not going to necessarily prevent the problem, because stress incontinence is multifactorial. So it's not just the delivery, it's being pregnant, your weight, other factors as well. So it's not currently recommended to do a cesarean section to prevent stress, but we do know that a vagina, if you've already got stress incontinence, and this is in one of the slides, and you have a vaginal delivery, you're less likely for it to resolve than if you had a cesarean section. So that's the only thing I found. I don't know if that's something that fits in with your thinking.
Yeah, I was just wondering if you had picked up anything new, but absolutely, I think it's so multifactorial that we often don't know, but it is confusing sometimes to us, because we see these patients who come with, but I think maybe when you do the Caesar is also important. I mean, if you do a Caesar full dilatation, the damage is most likely been done already. So and I know Pete's also given quite a lot of talks on this, and I don't know if he's got an opinion about this either, Pete.
Yeah, thanks, Steve. Without wishing to interrupt Judy, I think that incontinence and prolapse are two entirely different things, because as Judy has mentioned, incontinence, and as you say, comes and goes irrespective sometimes of the mode of delivery, but certainly prolapse is made worse by vaginal delivery, particularly repeated vaginal, particularly by difficult vaginal delivery, and a cesarean section, particularly elective cesarean section, is protective of prolapse. Thank you.
Yeah, so I purposely didn't do any prolapse things today, because otherwise it gets quite extensive. So I thought, Wendy, if we could do our first poll, which is, what is the most common urinary complaint of pregnancy? Basically, single best answer. Is it feeling of incomplete voiding? Is it frequency, urgency, urge incontinence, or stress incontinence? And I'll give you a few moments to vote.
People are used to voting now, so this should be quite quick.
I had a patient deliver yesterday, Steve. Nice little boy. What do you think we called him? We called him Voter.
Okay, good old man joke. Wendy, are we ready with the results?
Wendy, can you show the results?
They should be up by Sunday.
Yes. There's still a few votes going in.
I think voting is complete. Please count.
Okay, I'll count now. So we have 76% in frequency and 14% feeling incomplete voiding, and then 3% urgency, 3% urge incontinence, and 3% stress incontinence.
Okay, great. So the correct answer was frequency, because up to 80% of women will experience frequency during the pregnancy. Okay, now I just have to... Okay, so urinary symptoms that occur in pregnancy are frequency and urgency are very common. As I said, frequency and nocturia up to 80%. And this is due to a number of factors, but mostly due to the increased urine output due to this increased glomerular filtration rate, as we mentioned before. But the the thing is, these symptoms are also associated with urinary tract infection. So even though these are common complaints of pregnancy, you must be aware that these symptoms can be associated with a UTI, which actually requires treatment in 4% of pregnancies. In addition, your bladder capacity actually is reduced with the advancing pregnancy. So if you compare bladder capacity from the 3rd trimester to the 1st trimester, it actually decreases by 100 mils. When you look at the prevalence of this urgency, frequency, and urgent incontinence, it can occur in about 3% of women at 12 weeks and increases up to 15% at 36 weeks of gestation. And it definitely has an adverse impact on quality of life. So I always say these minor complaints of pregnancy that everyone brushes off, you only realize when you're actually pregnant, they're not so minor and they do impact you. Urodynamics, they have found that 8% of pregnant women may develop detrusor overactivity, with 31% showing a decreased compliance. Now, looking at stress urinary incontinence, this is also multifactorial. It could be due to the urethral sphincter incompetence, and this is caused by the combination of your pelvic floor muscle weakness and increased mobility of the bladder, neck, and urethra. Logically, the more advancing the pregnancy, the increase the weight on the pelvic floor, so higher intra-abdominal pressures. And also we mustn't forget the maternal weight gain. And I think this is something that we really need to focus on, because women are picking up more weight than is recommended in a pregnancy, and that can actually aggravate. So it's also part of the lifestyle advice that one you should generally give to watch your weight gain. Then also constipation, one of those minor complaints of pregnancy that are not so minor, can also aggravate the situation. So what is the prevalence of stress urinary incontinence? This has been reported from 19% to 75%. 73% of women with stress urinary symptoms pre-pregnancy have these symptoms during pregnancy. So basically, if you have stress incontinence before you're pregnant, you will most likely have it while you're pregnant. In those who have de novo stress urinary incontinence, so the incidence of a woman who actually developed this during the pregnancy is about 12.6%. Usually resolves postpartum, and the mode of the delivery can affect whether there is stress urinary incontinence resolves postpartum. I've got another slide about this as well. And vaginal delivery increases the long-term stress urinary incontinence by 8% compared with cesarean section. I actually think I might have deleted that slide, but basically it was stuff that I've already mentioned, which was that it's not recommended to do a cesarean section, but there is a correlation with vaginal delivery, especially prolonged second stage. So the longer you are in the second stage, the more likely you'll have postpartum stress incontinence. So now, how do you manage this? So interestingly, pelvic floor muscle training is generally considered the first-line treatment for stress incontinence, and it has been well established in women outside pregnancy. However, there is a Cochrane review on looking at trials in preventing and treating urinary and fecal incontinence in antenatally and postnatally, and this is 38 trials with about almost 10,000 women. There are unfortunately only small studies, and there was a concern about the study design and the reporting, so the evidence level is low. But this Cochrane review found that structured pelvic floor muscle training in early pregnancy in incontinent women may prevent the onset of urinary incontinence in late pregnancy and postpartum. So basically, if you want, it's more useful in prevention strategies, and basically you need to do this in early pregnant in women who are already continent. Because what they did find is women who've already incontinent, it is uncertain whether pelvic floor muscle training during pregnancy reduces the leakage in late pregnancy or in the year following childbirth. And it is unclear if it helped women with leakage after giving birth. So they didn't actually found it was as beneficial, but then the author's comments was the evidence level is low. So it would be interesting to hear what the physios listening have to say about that and what their experience is. But I found that very interesting because that's generally many things that we advocate for. But I think one also must remember the pelvic floor muscle training is not only for stress incontinence, it's for other factors. You know, I was always very interested in back pain in pregnancy, and that has been found with your core stabilizers to help with back pain. So there is still benefit to do that as well. So what about surgeries for stress incontinence? Well, it's not usually recommended to do any surgical procedure for stress incontinence until the woman has completed her family. However, if women do desire pregnancy after the incontinence surgery, you need to discuss that there is a potential for surgical failure if they do become pregnant. But at the moment, it's not really clear whether the mode of delivery actually affects stress recurrence. So in other words, if they've already had a stress incontinence procedure, a mid-urethral sling, and they are pregnant, does the mode of delivery impact on the recurrence? At the moment, there's not clear evidence either way. Also, once again, I'd be interested to hear what the experts have to say. So the other symptoms are overactive bladder, and there are currently no specific treatment guidelines for overactive bladder in pregnant women. So a lot of the treatments have either been based on the standard treatment guidelines, but also over the years what people have been using and etc. So once again, lifestyle modification is very important, modifying your fluid intake. However, you also must be conscious of the other advice, which is drinking fluids to prevent urinary tract infections. So I think you have to just adopt a balance. You need to reduce and stop any stimulants, pelvic floor exercises, and bladder retraining.
Judith?
Yeah.
Judith? Oh, sorry, you're going to talk about, yeah, I was just going to, we've got a question from Mabib of Nairobi, but I think that's what you're addressing right now.
Oh, is his question about, what about medication?
Yes. Is it safe in pregnancy? But you're going to tell us right now.
Okay, so as far as I can have been able to determine, it's the anticholinergics in, for example, oxybutynin immediate release has been used the most often and most researched drug for treatment of overactive bladder. It is a category B drug, which means it has been studied in animals, but not in humans. So the safety aspect has not been fully established, but it has been used in pregnant women, and also especially in pregnant women with spinal cord injuries with no adverse effects. So I didn't find anything about any other medication. The review article that I read specifically stated oxybutynin immediate release. So I think it's just probably because that's the oldest drug on the market. And they didn't even discuss your newer agents like your Betmega, etc. What was very interesting that I didn't know before is that it can affect your breast milk supply. So it's not generally recommended to give in women who are breastfeeding, as it can cause lactation suppression. What about other options? So intravaginal estrogens. That's not going to be helpful antenatally because you already have a high estrogen environment, but postnatally, especially in the breastfeeding woman, it is recommended, and we know that this is often the case, that they get vaginal atrophy, dyspareunia, so definitely intravaginal estrogens are recommended in the postpartum woman. And then what about Botox? It may be used in pregnancy, but is not usually recommended. There is a reporting a safety database, and I think there's like 24 years of experience. And from that safety database, it looks like that Botox injection during pregnancy showed the same pregnancy outcomes as in other rates. So it doesn't look like it affects the pregnancy in any way. But Botox in general, you must always be aware that it can cause urinary retention and the subsequent need for clean intermittent self-catheterization. So you need to be aware of that, especially in a pregnant woman.
Sorry, just want to mention something about the Premarin. I think it is very much underutilized, as you said, in postpartum patients, and we can definitely use it. And I think it does make quite a big difference to some of those patients. But just remember that package insert of the Premarin is a bit of a headache, because they use the same package insert that they do for the other Premarin, the oral Premarin, and the patients will always come and ask you, because it says on their package insert that it's not shouldn't be used in pregnancy. So we should just inform patients about that, and maybe even get the pharmacist to throw it away before they give them the the actual tube.
Yeah. Okay. And then I didn't think to talk about the other methods, because there was not really good data or evidence to support your sacral nerve modulation, your tibial nerve stimulation. So I just left those out. So I think this is the slide that I thought was coming up, and that's stress urinary incontinence and the postpartum. So there is definitely a correlation between the length of the second stage and the development of subsequent stress urinary incontinence. Yes, there's a high absolute risk for stress urinary incontinence when the patient delivers vaginally versus cesarean section. But doing a cesarean section, on the other hand, is not protective against preventing postpartum incontinence. So to say, let's do a Caesar so that you will never have stress incontinence, you cannot actually take that, promise that. So the current evidence is not to support routine use of elective cesarean section to prevent incontinence. So the next scenario, and, you know, as I was reading about this, I was thinking to myself, you know, I'm pretty sure I've had these cases, I just didn't realize this was happening. And that is, there is, because of the physiological changes that happen in pregnancy, but as well as to other factors, a patient can develop acute hydronephrosis. So this is something that it's basically symptomatic hydronephrosis that occurs in less than 3% of cases. And it's due to the usual increased diuresis that it causes, but there might be small stones or other unrecognized obstruction elements that may cause the sudden decompensation of ureteral function. And if untreated, can progress to life-threatening infection like pyelonephritis. And but basically, if you have it, it's 90% of cases will resolve with conservative treatment, analgesia, IV fluids, and IV antibiotics if there's signs of infection. But very, very rarely, ureteric stents might be required, in other words, double J stents or percutaneous nephrostomy. And this would be in cases where despite all your medical management, there is no improvement and there is deteriorating kidney functions. So now I wanted to do the next poll. So if you could do the next poll for us. So basically, to decrease the risk of UTIs in pregnancy, pregnant women should stop having sex from the first trimester onwards, be screened for asymptomatic bacteria regardless of the urine dipsticks. In other words, if the urine dipsticks is negative, wipe from front to back after defecation, be told to keep the perineum clean and improve their vaginal hygiene.
While we wait for those results, Pete, are you doing routine screening for asymptomatic bacteria in your patients, or do you do it more? I mean, I know we probably get into this a bit later, but is that something that you do in your practice?
Only by dipsticks, Steve, not sending
Okay.
MSU away on everybody. So if the dipsticks is negative, then I'd leave it at that. If the dipsticks is positive, I would send it away, yes.
Okay, so you use the dipsticks as your sort of screening, initial
As a screening, because they're very sensitive. They're very, very sensitive. So I'm happy to do that as a first-line screening method.
Okay. Those results out yet? Or not?
Yes, they are. So we
Okay.
have 57% for the screening, and then 30% for wiping from front to back, and 13% to be told to keep the perineum clean and improve vaginal hygiene.
I did this question on purpose because there's a little bit of truth to some of all those statements, but I thought to put the single best answer. So currently, in first world countries, it is recommended to screen all women for asymptomatic bacteriuria, regardless of the urine dipsticks. And it's in our state practice, it's actually something that we should be doing as well. I'm going to show you just now a maternity case record, but it's unfortunately not always done. Okay, and then wiping from front to back is actually true. I meant to say from back to front. It's a preventative measure, but I thought the single best would be B. And then, yes, you want to have good vaginal hygiene, but to tell a woman to just keep clean can be sometimes quite, they might take offense. And yes, we know the frequency of sexual intercourse is linked to cystitis, but also, once again, it's not practical or helpful to tell a woman to stop having sex completely.
Sorry, Julie, just which way did you say you should wipe? Front to back or back to front? In other words, from the bladder to the anus or the other way?
It's from the front to back.
So from the bladder to vagina to anus, yeah.
I think you've got it right there, actually.
That's what I was saying. As I looked at the pictures, I said, oops, I did it. I thought I didn't swap it around like I was planning to. Okay, but never mind. Moving on. So that's why I said single best answer. So when you look at urinary tract infections in pregnancy, you can divide them in those of the lower urinary tract or those of the upper urinary tract. When you're looking at lower urinary tract, you get asymptomatic bacteria and cystitis, and upper tract pyelonephritis. Sorry, my computer's a bit slow. Okay. So asymptomatic bacteria is defined as bacteria. That means it's basically no symptoms with more than 100,000 organisms per mil, 10 to the power of 5. But interestingly enough, women can have urinary tract infections in pregnancy with organisms as only up to 10 to the power of 3, which is 1,000 organisms to mil. And the argument was that the old-fashioned assessments of looking at bacteria in the urine often missed certain bacteria or bacteria of low volume. So and hence the concept that urine is actually not sterile anymore, as what I was taught at medical school. There's actually organisms there that we are not just unable to detect. So asymptomatic bacteria occurs in 47% of pregnant women, and 40% will develop a symptomatic UTI. So they will go on and develop a symptomatic urinary tract infection. Of those women with asymptomatic bacterial, 30% will go on and get acute pyelonephritis. And the problem with acute pyelonephritis, that is linked with preterm labor, preterm birth, low birth weight, and poor neonatal outcomes. So hence, if you look at the, I don't know if anyone else has noticed it, in the new maternity care book that women have now, part of it is having a screening urine culture. And unfortunately, that often doesn't happen, but it is recommended that you screen at least once in the pregnancy. And that's the practice now. Well, certainly in the hospital I was working in, that's what we did.
Sorry, do you mean by screening, you mean a midstream urine MCNS?
Yes.
Yeah, because that is quite expensive in private. It's just under R1,000. And,
yes,
you know, usually we have to ask the patients if they're prepared to have it. When they hear R1,000, they say no.
Yes. So we have actually, I'm going to talk about it in one of the other slides, because the standard microscopy culture and sensitivity, that has is quite expensive. The last time when I worked at PAR, we asked our lab what's a urine MCNS, and it was R400. But if we removed the microscopy component of the culture, then you would get the cost down to R200. So I'm not quite sure what the cost would be in private. And I remember Prof. Tron, when I was a registrar, he always used to say, don't do the microscopy just as a screening, just do the culture, because the microscopy in itself has got a high false positive rate. So completely ignore the microscopy and only do a culture. So that's essentially what we do is we say growth only, no microscopy to decrease the costs. And you essentially are just trying to see if you can detect the bacteriuria. I don't know if that helps at all. Yeah, and the causative organism in the majority of cases is E. coli from the patient's own gut, but other organisms are Klebsiella, Proteus, and Pseudomonas. And the colonization of the urinary tract is an ascending infection from the perineum, and so hence sort of keeping the perineum clean is actually correct. And also sexual activity allows these organisms to be able to ascend more easily. But we do know that treating asymptomatic bacteria will reduce your risk of preterm delivery and low birth weight. So, and I think in a public health setting, where your cost of preterm delivery, I mean, our preterm delivery rate, I don't know if there are obstetricians in the audience, is something like 20 to 40%, I think. I think the cost of a preterm baby, you have to weigh it up against the cost as well. So I think that's why they've decided to include it in this antenatal screening. So what antibiotics do you use? So generally a penicillin, a cephalosporin, or nitrofurantoin. Fosfomycin is becoming more and more used. Just to bear in mind, I think with fosfomycin, you mustn't use things like citrus soda. They affect the efficacy of the drug. I remember the rep telling me once that, because often people get citrus soda with their antibiotics if they've got symptomatic UTIs. The only thing with antibiotics is everybody's always concerned about antibiotics and the baby. So nitrofurantoin causes a theoretical risk of neonatal hemolytic anemia. So it is considered a category B. And then your trimethoprim should be avoided also in your first trimester. So for example, we often would use Bactrim, which is the combination of your sulfonamides and your trimethoprim. And just remember, trimethoprim is an anti-folate drug, so you don't want to use it in the first trimester. And then also, once again, long-acting sulfonamides increase the risk of neonatal kernicterus if given in the third trimester. And I remember when we used to give lots of Bactrim for, I think, our PCP prophylaxis. I remember once one pharmacist didn't want to issue the Bactrim because the woman was pregnant because of this, and then we had to have a discussion.
I'm sorry, Julie, can I just make a comment? And I think amoxils, there's very high resistance levels to amoxil in our community. So even in the state practice, I remember us being able to give Augmentin for those patients, although I don't think we really like using Augmentin in pregnancy. So I don't know if amoxil is really a good one for pregnancy.
Yeah, no, I just included it because this was the recommendations from the article I read, but it wasn't a local article, so I think it wasn't necessarily specific for our cultures. But yes, I think you just need to bear in mind your local sensitivities.
So Judith, just to finish Steve's sensitivities, phosphomycin is a once or 3 gram sachet, and there's now a generic available, which is very inexpensive actually. It's half the price of the originator. So that's what I use in my practice for private patients.
And actually, to be honest, we looked at the national, or we looked at the guidelines recently, because at part, I don't know if you're aware, there's the stop and save. So we were looking at the cost of nitrofurantoin, macrodantin versus the cost of phosphomycin, and a once-off dose of phosphomycin was cheaper than nitrofurantoin in the state sector and easier to use. So I think, and then we also went to go and look at the guidelines. In uncomplicated UTIs, phosphomycin is now considered the first line agent in pregnant women.
On that point, sorry, another very practical point, which I think is important. I've been giving them 2 doses of stat and then 1 3 days later. Are you guys doing that? That was recommended by one of the microbiologists to me. I don't know any data or any evidence on that. But
I must admit, I have heard that treatment regimen as well. But currently in the state sector, we just do a once-off dose.
No, I mean, I don't have any evidence for that, but that's what the microbiologists are recommending to me. But that might then double the cost, which makes it a lot more of a challenge.
Yeah. But I think it's still cheaper, the generic, than macrodantin. I was actually quite shocked at how expensive macrodantin it is. I thought that was one of the oldest antibiotics, but it's actually not so cheap. Okay, so moving on to acute cystitis. It's basically a woman presents with urinary frequency, urgency, dysuria, hematuria, proteinuria, and suprapubic pain. The risk factors are diabetes, steroids, and other immunosuppressive conditions, and then, of course, a history of recurrent UTIs. Also, interestingly enough, in the one review article that I read on global prevalence of UTIs in pregnancy, there's a link between cystitis in pregnancy and preeclampsia. So, which is something that I wasn't aware of before, but maybe the obstetricians in the audience have heard that. So that was quite interesting. So I don't know if it's the inflammatory mediated process, but there is a link between cystitis and the development of preeclampsia, interestingly enough. So how do you diagnose it? Well, you need to do a midstream urine specimen. And this is where the microscopy comes in. Yes, microscopy of the urine may reveal organisms, white cells, and occasional red cells. However, the false positive rate is very high and is no longer recommended for the diagnosis of UTI. So you can't say because there were 100,000 white blood cells that there's a UTI because of the high false positive rate that occurs in pregnancy. Also, the presence of nitrates and leukocytes is suggestive of a UTI, but not diagnostic. So the one place, the majority of organisms, I think it has to do, the reason why it comes up is the organisms change the nitrates to nitrites, but not all bacteria change nitrates to nitrites. So dipsticks, your dipsticks can be negative or have no nitrites, but there is still a urinary tract infection. So I thought, Stephen, you might be interested with that information.
Oh.
And all of this puts you at increased risk of acute pyelonephritis. And this acute pyelonephritis occurs in 1 to 2% of pregnancies. Yes, asymptomatic bacteria, cystitis, etc., all risk factors, but you also must think about other conditions that might be occurring, like congenital tract malformations, kidney stones, and then also the neuropathic bladder. In the last few years, I've had paraplegic patients who do intermittent self-catheterization, and they were very many recurrent urinary tract infections. And interestingly enough, I had my paraplegic patient had, every time she would have nitrates in her urine, but nothing grew. And then I figured out that she was doing the in and out catheter at home, and then would only bring the specimen, and it would only, when they dipsticked it was already a couple of hours old. And apparently if you dipsticks old urine, your incidence of nitrites is higher than fresh urine. So you have to have fresh urine. So I had to actually start telling her she needed to do an in and out when she came. And I think that was always the difficulty, is that this was when I worked in the rural areas, there wasn't actually a place for her to do an in and out catheter. So that's just a bit of interesting information. So typical symptoms of fever, loin and flank pains, and the other cystitis symptoms, but also feeling systemically unwell and preterm labor. How do you manage this? Well, you want to do your cultures, both your midstream urine and blood culture if the patient is febrile, but then treatment needs to be aggressive with IV fluids, analgesia. I think we forget to give adequate analgesia. It is quite painful. And then to give...
Very painful.
Yes, to give the penicillins like the Augmentin, or the cephalosporins like cefuroxime or ceftriaxone. Then if it is recurrent or complicated, to screen for do a kidney ureter bladder ultrasound to look for underlying factors. Especially if it's atypical. For example, you normally get hydronephrosis on your right. So if the patient presents with a left flank pain, then think there must be something else going on. Go and have a look. And then postpartum, you might have to investigate further to look for other abnormalities or things like stones. So what about antibiotic prophylaxis? So this is usually recommended if you have recurrent urinary tract infections. When you're not pregnant, this is considered if you've had 3 episodes in the past 12 months or 2 episodes in the last 6 months. But in pregnancy, it's deemed recurrent if you have had 2 episodes of UTI which have deemed a positive culture and associated with lower urinary tract symptoms. Also, once again, if it's recurrent, look for underlying cause. So the antibiotic prophylaxis. So here they have either the trimethoprims like the Bactrim or nitrofurantoin, but also the amoxicillin or a cefalixin. So I think, as you mentioned, most people won't use amoxicillin as prophylaxis anymore, but you can use a low dose of a cephalosporin like cefalixin, 125 to 250 milligrams. The once daily, normally overnight. And the nitrofurantoin is a low dose antibiotic. Sorry, my computer's a bit slow. Or I'm pressing too hard, so I just need to check.
Steve? Hello, Steve?
Pete, yeah, I'm here.
Hello.
Yeah. Hi.
can you just do some of those questions? Are they a bit, we don't want them
Okay,
to
I
sort
thought
of
I was leaving them at the end, but yeah. Oscar Shimang is asking, do we still use an MSU for urine microscopy? And I think we have discussed that in some detail.
Yeah, so we don't use it if we're thinking it's infection, but if I'm thinking something else is going on, I do sometimes ask for microscopy just to see if there are casts or something else that is not usual, but not if I'm thinking just UTI.
Okay.
Just to
And then-
decrease the costs, actually. Stop and save.
Yeah. And then Lawsi has asked, what degree of hydronephrosis is considered physiological in pregnancy? And when should patients be referred to urologist or a urogynecologist for intervention?
So
I think you
this
did
is
have some numbers there, hey?
yeah.
In your
Yeah, I
QR.
said 5 on the left, 18 on the right. I know there's mild, moderate, and severe. And I think the physiological changes of the right kidney fit into the severe category. And this is the frustrating thing, is when I worked at the radiographer always would write severe hydronephrosis, but never give me the actual AP diameter. And then I'd have to go and look at the pictures to see the measurements to actually try and figure out if this is really something that I need to get a urologist involved or not. So I think knowing the cutoffs is useful because your sonographer might not be aware of the changes, the cutoffs of pregnant women. So they will often report it as severe hydronephrosis. I don't know if that's what if your ultrasonographers do that as well.
Judith, if it's asymptomatic, then it doesn't really matter, is it? Is that true?
No, it doesn't really matter. And to be honest, I wouldn't normally routinely do a KUB ultrasound. However, I did see one study where they were actually looking at routine KUB ultrasounds at the when women came for growth scans and detailed scans. And they also found high rates of hydronephrosis in all 3 trimesters, but it didn't always correlate with symptoms or outcomes. But the argument of the authors is if you did see it, you might be more, have a high index of suspicion if your patient does have problems, or if you don't have the practice of doing screening for asymptomatic bacteria, you would definitely then do it if you see it coincidentally.
Okay,
So
thank you.
Yeah.
And
So
then
how do
the last question, Dr. Kwanzura, up to what gestation can we use nitrofurantoin? He has a client concerned about it when prescribed it based on the sensitivity at 37 weeks. Can you use it up to term, or when would you not use it?
So I think the main concern was the theoretical risk of the I think was it hemolytic anemia in the newborn. But I think you also have to, like most things in life, you have to balance the risk versus benefit.
Okay.
And to be honest, a urinary tract infection in a pregnant woman can be both harmful for patient and the baby. I think generally you can argue with your patient to say that the benefit outweighs the risks.
Okay, thank you.
So the next was to talk about preventing urinary tract infections. So they talk about emptying your bladder after sexual activity, wiping from front to back, drinking adequate amounts of fluid, controlling your blood sugar, and then double voiding to ensure no residual volume. And then many people say cranberry juice, but the one review article said no to cranberry juice, but they didn't say why. So I just am putting the question mark cranberry juice.
Yeah,
so
I do
now,
actually just about cranberry. I think it's very important how you take the cranberry. I don't like the patients take the juice, even raw cranberry. So what I use these days is something called Elura, ELLURA. It's a very well dosed, well researched product. It's quite expensive, but I've been using a lot of my patients, especially if it's E. coli. It really only prevents the E. coli bladder infections, but it does work well, and there's some good evidence for it. So people can go and look at that and see if they want to give patients that as well. And I think it's useful.
Yeah, because that would I wouldn't, because I'm actually, my next slide is on the I don't know in what group to put them in. Are they the homeopathic or non-prescription preventative measures? So they talk about ascorbic acid, which is vitamin C. This appears to be beneficial with no harmful effects. Then there's also something called Canefron, and I see it is available at Clicks for 219 Rand. It's basically a herbal product with antibacterial properties. I don't know if you've any experience with those.
Other patients take it. I'm not sure of any evidence for any of those options.
Yeah,
so
I think
makes them feel better. I'm not sure actually, but they take it. I mean, a lot
I
of
think
patients
it's like a lot of these I don't know what they're classed as, the drugs that they're not really actually studied, but they might be of some benefit. Then there's also something called methenamine hippurate or Hiprix, which is considered a urinary antiseptic. And then there's
on Hiprix, we did have a talk on recurrent UTIs the last year sometime, and the evidence for it was actually quite good, but it's not available in South Africa, unfortunately.
No, I didn't see
I tried looking for it in this cam in some of the places, but unfortunately it wasn't available. One of my patients' husband's actually a pharmacist. He was actually looking at bringing it in from Australia, but unfortunately not. Pity, because I think it does work.
Then the other agent, I also don't know if it's available in South Africa, is D-mannose, which is
available.
Is it?
Yes.
Okay. So it's a sugar that apparently prevents bacterial adherence to the uroepithelial cells, causing bacteria to be simply excreted in urine when voiding. So now I just wanted to, because I think we're running out of time.
We've got 4 minutes.
So I'm going to I think I'm going to move on, because I wanted to at least end off with urinary retention. If I could, and try and do this quickly, because I think this is actually something that I feel that is quite neglected, especially in the state sector. And we had a case of urine rupture postpartum. Now the question is whether it was a bladder injury that at Caesar that just wasn't detected, or inability to void and bladder rupture. But the patient actually, so it looked like she was voiding in the ward, discharged, and then came back a week later with an acute abdomen. And then there was a history that she was struggling to pass urine at home. So I'm not quite sure. And it's also, one of those she was low risk, you removed the catheter, and you basically discharge within 48 hours postpartum. So I'm not too sure. But I have definitely had urinary retention following vaginal delivery, which was undetected, which led to problems. So you can have urinary retention in early pregnancy, especially in women with retroverted uteri. And basically, as the uterus enlarges, it gets trapped under the sacral promontory. And one of the recommendations for that is actually to put in a pessary. They recommended the Smith-Hodge pessary. It was a UK article, but I think I last saw that type of pessary in the UK. And that was to help maintain anteversion of the uterus and relieve the obstruction of the bladder neck. But other things like enlarging fibroid or any other pelvic mass that can contribute to urinary retention early in pregnancy. And this usually does resolve and might be needed to teach the patient to do intermittent self-catheterization or an indwelling catheter. Then urinary retention can also occur during labor. And overstretching of the bladder can cause severe detrusor damage followed by voiding dysfunction. So the other question is, you know, how much of women's bladder problems is due to being neglected in labor. That's also something we can ask ourselves. And so women it needs to be assessed and monitored that women are able to pass urine during labor, and if they're not, to do it, to use catheterization if required. But bearing in mind, every catheterization process increases the risk of UTIs. So you do want to try not catheterize your patient, but intervene as necessary. Then postpartum urinary retention can occur in 14 to 24% of women, depending on the type of delivery. And the risk factors are whether it's the first labor for the woman, instrumental delivery, epidural, prolonged first and second stage of labor, if there were any perineal lacerations, cesarean section, and then also urinary tract infection. What is interesting is that you can have overt postpartum urinary retention, which is inability to void spontaneously within 6 hours of vaginal delivery or after removal of a catheter after cesarean section, or covert postpartum urinary retention, or silent postpartum urinary retention. That means the woman says she's able to pass urine, but she still has large post-void residual volumes of more than 150 mils of urine. And this can be confirmed by doing a bladder ultrasound scan afterwards. It does affect a significant proportion of women after delivery, but the significance of this is not really known. So I just wanted to go through this King's College postpartum protocol on trial without catheter. So basically, a woman should be able to void within 4 hours after catheter removal, and a further 2 hours can be given, totaling 6 hours. And then you need to document the voided volume. If they were able to void, then you need to have ask a certain set of questions, which they call, the acronym is VESI. And then depending on the answers, you can either have retention or not. If they're unable to void, then it's of course overt retention. You need to do an in and out catheter and to check the residual. So the basic questions are: did you pass a good volume of urine? Did your bladder feel empty at the end? Did you have sensation that you want to pass urine? Was your stream normal? And was there any incontinence? If they said yes, then in and out catheter to check the residual, and then depending on that, there would be a protocol. And if they said no, you would ensure that the second void occurs within 6 hours post-catheter removal, and then so on. I'm just going to, for time, go through that. You're more than welcome to get it afterwards. If they're unable to void and you do an in and out catheter and their urinary volume is less than 150 mils, then you would, it might just be that they just didn't have adequate volume. That would still be within normal. And then there would be an algorithm of, depending on when, what to do afterwards. And I think I'm just going to leave that there for the sake of time, but I was going to also talk about the rates of bladder and ureteric injury during delivery, often due to Caesar, and then vesicovaginal fistula. But I think I must just leave it there.
Judith, has been wonderful, and we've been so intrigued that maybe we can address these final chapters during another talk that would be trauma during delivery, and add that on, cobble that to prolapse caused by birth injury. So you being a urological fellow would love that talk, I'm sure, because it's something that comes up all the time. Just to knock off the final question of Graham Birdsley, who has, what do you do with repeated sterile pyuria? In other words, you can't culture anything at MSU. And I'd say, apart from looking for TB, do you have any clever ideas, Judith? Tuberculosis?
So, yeah, I think that's one aspect. But also, I think, does he mean because there's white cells in the urine?
That's
see
what Graham
that's-
Birdsley means, yeah.
So I think that goes back to the when you're pregnant, then you have a higher false positive rate with leukocytes on the dipstick. So I think the first thing I would do is check how the urine was collected. Was it a proper midstream urine specimen? Because that could contaminate your specimen. The second thing would be to just not consider that it's actually a false positive, because microscopy in pregnancy does yield a high white cell count quite often without infection. Or it could be, one of the things that I realized is that it could be just organisms that your lab is not able, or the usual culture is not able to
Identify.
Yeah. But I haven't got enough laboratory knowledge to tell you exactly why. But I just remember them saying that the classic 100,000 organisms in pregnant women, you can have less than that, and maybe your lab's just not reporting on the less organisms.
Okay. Just before I ask Steve to thank you, one or two last ones. Can we use D-mannose in diabetics? Yes or no? Can you just say yes or no, please?
I think it's a yes, because I think it's something that's excreted, but I'm not too sure. I'll have to double check.
Okay, final question from Anonymous. Some patients with post-catheterization after cesarean section respond after using lidocaine jelly applied to the urethra. Is this a good idea or a bad idea? Yes or no?
I think that is a good idea, because I think that a lot of trauma does happen to the urethra, and then you have these symptoms of dysuria. So I think it would be beneficial. But I think you have to, so I know some places do it as a standard method when inserting the catheter. I don't know about afterwards though, after removing the catheter.
Okay, thank you. So you're not sure. Steve, would you thank Dr. Judith Hooker, please?
Yeah, thanks so much. It was excellent, Judith. There's one last question from Judith Mambombolo. Prophylaxis for preventing recurrent UTIs. I mean, I think if a patient has repeated UTIs in pregnancy, you should probably continue prophylaxis through the pregnancy. Isn't that the common practice?
Yes, so 2 or more, you should keep them on prophylaxis. Yeah.
Then non-pregnant, I do it for 3 months, and then after that, try again seeing. But I don't know, any ideas from your side if it's a non-pregnant patient with recurrent UTIs?
To be honest, I haven't seen many of those in my up until now, but I will feed back to you.
Very lucky, because once you become a gynecologist, that will be your bread and butter.
So, yes, I think that will become my bread and butter.
And they're quite difficult patients to treat. So
I think also what I've realized is these patients often land up with urologists. The urologists do a scope, can't find anything, then they send to the urogyne. So that's my 6 months fellowship experiences. Urologist doesn't know what to do, and they send to us.
Yeah, so they do a scope. They'll do urethral dilatation, which is the most common treatment for it, and then they sometimes even do a retrograde, and then they often patients do respond, but then they come and see someone else. So, but anyway, thanks so much. It was a wonderful talk again. We do look forward to hearing another talk on those other much more complex things like serine hysterectomy and bladder rupture and things, and we can maybe do that in conjunction with one of our urologists. But I think that's a very important talk. So look forward to having you again. Of course, always great having you. It was very well attended. Thanks for the large amount of time you did in preparing this talk, and maybe you should put into some sort of review article form. I think that'll be very nice if you could do that. Okay. But thanks so much, and we do appreciate it. Good luck for your fellowship as you go to Tygerberg.
Thank you.
So much. Thank you. And thanks, Pete. And safe home, everybody. And see you next week.
Look forward to seeing you next week. Thank you, Steve.
Thank you very much, everybody.